Steve too. So next we're going to hear again from Jeff, and he's going to be joined by two of our Margolis visiting scholars. Mike Pignone is the new Chief of Medicine at the UT Dell Medical School in Austin, but also is still a Durham resident and has a long North Carolina roots, and more importantly for our purposes, a lot of leadership in new models of primary care, including interaction with specialty care. Steve Farmer, who's a clinician, a cardiologist at GW based in Washington, but has long been working with me on and with policy leaders on issues of primary and specialty care interaction. This is, cancer was a good introduction to this, but this is where a lot of the costs are, a lot of the disease burdens are, and a lot of the opportunities for improving coordination and delivery of care. So Jeff?
Thank you. So of course we've known for a long time that most death and disability and of course costs are involved in chronic diseases. And as Adrian mentioned earlier, we also know that real world outcomes often fall short of what medical science has to offer. And of course people have been trying a number of solutions, and at least at a national level, we've typically, these haven't achieved the desired goals of improving quality and reducing costs. Yet I think there are a number of reasons to be optimistic that this can change and that we can be a real part of the solution. First, there's a growing imperative. We know that healthcare costs are unsustainable, particularly for the Medicare program, which is catalyzing a lot of this change. And the alternatives to reducing costs through effective strategies are just almost unthinkable. So we have a real motivation to move forward, and there's nothing like a deadline. And I think that's reflected in the... Okay. Can you hear me now? All right. And I think that's reflected in the large number of providers who are voluntarily participating in these programs. Secondly, I think we've learned a little bit more about how to design effective strategies. Kind of early on, disease management strategies were often pretty narrowly focused on trying to get providers and patients to adhere to a specific set of services or pathways for limited diseases, events, procedures. We now know that the best opportunities focus on patients and populations more holistically, address some of the interaction of not only multiple chronic conditions, but also system factors and even non-medical determinants of health. In fact, some of the early, most promising findings we've seen, such as in the accountable care organizations I mentioned earlier, have come specifically for those patients who have a number of multiple severe chronic conditions. Third, I think the solutions that we're developing now, particularly the payment models, give providers a lot more flexibility, allow them to innovate locally. They generally are outcome-based and allow a lot more room for innovation. And then finally, I think some of the data sets that we've already mentioned earlier, they're going to give us a much better information, much better expertise to identify the best opportunities. I would like just to highlight as an example, particularly since we're on the subject of cancer, CMS was nice enough to coordinate the launch of the oncology care model today with us. For those of you who aren't familiar with this is by far the largest specialty physician-directed alternative payment model to come into existence. Mark and I actually worked on the design and development of this early on and produced a lot of the foundational evidence to guide this model. And there were many inside the government and externally that thought CMS and medical oncologists would never be able to agree on this type of model, but they've announced that I think about 3,200 medical oncologists are participating in the model as of today. And of course, there's still a lot to be done to understand how to measure and reward value, but there's going to be a lot of money flowing to real doctors who are treating a lot of patients, who are going to, and a lot of data, and they're going to be able to start experimenting with innovative models, and I think we're going to learn a lot in the near future, and we have an opportunity to be part of that in particular. So now I'd like to, I guess, first give Mike Pignone a chance to say a few words. Are you going to stay over there?
Thanks, Jeff. Greetings to everybody, and howdy from Texas. I'm learning that slowly but surely. I'm Mike Pignone. I was Division Chief of General Internal Medicine at UNC and actually spent 20 years at UNC prior to assuming this new role as Chair of Medicine at Dell Medical School. And for those of you who don't know, Dell Medical School is a new medical school at the University of Texas, Austin, which was the last of the major research universities really in the whole country to not have a medical school affiliated with it. So we just welcomed our first class of 50 students to Austin, and their energy and the energy of the Austin community has really been palpable as we get this new medical school up and running. One of the nice things about the new school is it's really focused on value-based care and bringing health to the population. The school's origin was that the people of Travis County, which is Austin's county, voted themselves a property tax increase to fund the school, and the care of the underserved and population health is really at the core of what the school is about. So I think we're going to have in Austin a really good laboratory to test and implement and spread some of the ideas that will come out of the work here at the Margolis Center. I'll be spending Fridays here in Durham for the foreseeable future and plan to be at the center, collaborating with people here, and hopefully building that connection between Austin and Durham and Washington so that we can really learn as quickly as possible what kind of solutions actually work in more than one place, so we'll have a bigger laboratory. So I welcome the chance to work with you all and look forward to it.
And then, because we know that many of the best opportunities occur sort of between that primary and specialty care interface, which outside of an integrated system like Duke are very hard to organize. Steve Farmer is going to talk a little bit about some of the work he's been doing in that regard.
I'm Steve Farmer, Associate Professor of Medicine and Health Policy at GW and Senior Advisor to the Center. I wanted to tell you a little bit about a project I've been working on with Mark for some time now. It began in the fall of last year. In looking at the proliferation of alternative payment models, what's really clear is that there really isn't one which establishes joint accountability for primary care doctors and specialists and is applicable outside of integrated delivery networks, which is a situation which a very large proportion of providers find themselves in. So over the past months, I've been working with primary care doctors, the professional organizations of the ACP and the family practitioners, as well as the American College of Cardiology to think through how we can approach a better system of joint accountability. And out of that, we've developed a framework for different ways in which we can better work together. And we are thinking through the payment models which will better support more idealized approaches to care. Of course, this is quite a challenging area because of the heterogeneous patient populations that have chronic diseases and the fact that they don't just have one at a time, which would be convenient from a payment standpoint, but is not the reality. So it's been a challenging project, but it's a very important one, and it's wonderful to get support for it.
Thank you. Thanks, Steve. And next, we're going to hear again from Dawn. While Dawn's going up to the stage, this is going to focus on. We've talked about chronic disease management and the pathways for patients who are going through what had been maybe acute diseases, now increasingly chronic, like cancer, and the burden associated with that. In thinking about care from a patient standpoint, though, it's not only about traditional medical services, but also about supportive services and for more advanced disease, palliative care, hospice care, and the like, which should all be integrated.
Thanks. Seth, have the next slide, please. All hospice care is palliative in nature, but all palliative care is not hospice. In the Medicare program, the rules say hospice is for the last 6 months of life, but the median length of use of hospice in Medicare is 18 days, so less than 3 weeks. A big part of what we're trying to do is figure out how to push palliative care further up the life course and engage patients and even families earlier in this process, because it's not only patients who are dying, who are approaching death, as all of us are, but their families are as well. So next one, please. So the only thing everybody in this room has to do is die.
Can I just, as a policy expert, I have to
Yes.
add tax payments on top of that?
Yes. Actually, we could probably find some people in net terms maybe that don't pay taxes, but yeah, taxes and death. But Actually, when I teach Intro to U.S. Health System, I start with this. I say everybody's going to die, and before that, the healthy subsidize the sick. And it's actually not what the 19-year-olds thought they were signing up for usually. But so what I want to talk about real briefly is a personal story that illustrates some of the context of the Center for Medicare and Medicaid Innovation Palliative Care Award that we have. And I have here on the slide my story, but it's really my grandmother, my mother's story. So about 100 miles east of here today, my grandmother, who just had her 93rd birthday, is rapidly approaching death. And she's had a really good life and really had about 91 years of incredible health. In fact, when she was 91, the family decided that I was the one in the family that needed to tell her she couldn't drive anymore. And I did that, but she was still driving it at age 91. She's had a series of strokes, and my mother, who's 74 and who has Parkinson's disease, is spending most of her waking hours trying to figure out how to care for her mother. And so if you think of that image, a 93-year-old and a 74-year-old, that's a human story. That's my mom and my grandma. But if you want to think about the problems with the Medicare program, that's 2 generations of Medicare beneficiaries for 1 generation of taxpayer. So usually when you think of social insurance programs, the idea is I'm paying now for the next generation is going to pay for me. So we're now paying for 2 generations. And so the question becomes, how does my grandmother have a good death? A secondary question is, how do we figure out what that means for my grandmother to experience a good death without actually killing my mother or making her life even worse? So these are the kind of questions that go far beyond the types of payment policies that we've traditionally had. Now, my grandmother, has a really good primary care doctor. She's had this same primary care doctor for about 25 years. That's a pretty unusual story, right? But she lives in a small town. He's gone to her house several times and really helped my mom and her decide what to do and what not to do. So my grandmother's been hospitalized 5 times since Easter. So that is a terrible, terrible kind of financial disaster for the Medicare program. And the other thing is, every time she's gone to the hospital, people who thought they were doing the best for her, they would call 911 like if she fell. They didn't know what else to do. And so the Medicare program will pay every time my grandmother falls, and they take her to the hospital, and they clear her neck to see if she's got a C-spine injury. They see if she's broken her hip. But we don't really pay for what you might think of as high-touch, low-tech services that might better care, for my grandmother at home and maybe reduce the likelihood that she might fall again and go off to the hospital. And so this is just a personal story just to illustrate the broad context into which the CMMI project actually exists. Everybody, well, I'm not sure about everybody, but most people think that the hospice benefit has done lots of good for many years, but it's not really enough, and we need to figure out how to take this type of care further up the disease course. And so we here at Duke are working with our clinical partners, Four Seasons out in Western North Carolina. They have this innovative clinical model. They're demonstrating it. We are measuring it. We're looking at the cost and looking at the quality, and we're asking the question, can we do this care and make people a little better as they approach death, and hopefully cost the Medicare program a little less? And from that, what we're trying to do is change payment policy to try to incentivize this better care, to get away from the system that we have now, in which we will pay endlessly for the acute care or the rescue care, but we have undervalued the discussion care or the support of families to figure out how to care for their loved ones. So this project it's a really great demonstration of what you can do at Duke, because it goes across so many parts of Duke, but it's also a demonstration of what we're trying to live into to make the country a better place. And when people sometimes say, what's your big point about the project? I'm thinking for us to have a better Medicare program or a better, policy context for when I'm a Medicare beneficiary. So it's just one thing that we're trying to do. So thank you.
Thank you.